Good morning, everybody. Welcome back to Grand Rounds. That's the first Grand Rounds for 2025, and it's a great pleasure for me to have today's speaker here, Dr. Shrestha from the Mayo Clinic. First, I would like to thank our sponsors today for supporting us with Grand Rounds. It's Edwards Life Science and Octa Pharmaceuticals, so thanks you very much. And today, we have Professor Shrestha here from Mayo Clinic. It's a great pleasure for me to introduce him. I think yesterday we talked about it. I've known him now for 15 years, and we have been a long way together. I'm from Germany, and he's from Germany too, originally from Nepal, but he was my mentor for about 15 years. I learned a lot of things from him, how I do surgery, and I'm very thankful for all of that he showed me. And it's a great, actually, that's the first time I have to introduce him now. I just found about that out, so it's very exciting. So Professor Shrestha is director of the Aortic Surgery Center at Mayo Clinic and a professor of surgery. He's completed his residency in Germany, where also I did my training in Hanover Medical School. He also earned his PhD there. And before moving to the Mayo Clinic in 2022, he was professor of cardiac surgery and the vice chairman of the Department of Cardiothoracic Surgery, Transplantation and Vascular Surgery at Hanover Medical School. He has been the principal investigator of many clinical trials, including the Percival sutureless valve trial, the Edwards intuitive valve, and the Toraflex frozen elephant trunk prosthesis from Terumo. He performed many first-in-man procedures in the field of cardiac surgery, including the Percival valve, intuitive rapid valve system, and again, the Toraflex hybrid graft. And he also is the co-developer of the Toraflex hybrid graft. He also is involved or was involved in the development of the Edwards Connect root graft. His interest is in the field of aortic surgery and new devices, and it also has an interest in valve-sparing aortic root replacements and total arch replacement with the frozen elephant hybrid graft. Today, he's going to speak about treating patients with aortic regurgitation and root dilatation, valve-sparing, bioprosthetic, and conduits, and more. Thank you. Very excited.
Thank you very much. Good morning. Happy New Year. So today I'm going to talk about aortic valve regurgitation with root dilatations and different techniques, how we can treat them. And it's a big pleasure to be here. Unfortunately, I just, in the night, I got a text from Vinny that he is not here. So I'm a consultant for Terumo Aortic and Edwards Life Sciences. But the talk right now, what I'm going to give, has nothing to do with my consultancy work with them. And my only other disclosure is that over the last 20 plus years, I've personally performed more than 300 valve-sparing aortic root replacements, the David procedure. So I'm a little bit biased towards it. So first of all, again, I want to thank Vinny Bapat for the invitation here. It's a pleasure to be here. So like Dr. Beckman just said, so I spent 26 years in Hanover Medical School. I did my residency there, and after finishing residency in 2002, I joined the faculty, and then from over 2003 to 2022, I had different functions there, staff surgeon, chief staff surgeon, and then finally last 6 years as the vice chair of the whole division of cardiothoracic, transplantation, and vascular surgery. And then I moved in October 2022 to the Mayo Clinic. So basically from a relatively new university, established in 1965, to a very old one, at least compared to Hanover, 100 years older, the medical institution, the Mayo Clinic. So, and of course, I've known Eric for many, many years, since he started as a young resident, So, of course, I don't know how many nights we've spent doing these big surgeries, especially after he finished his residency, then he joined our group, the aortic group. So we had really fun time, I would just say that, and also a lot of nights together, doing a lot of thoracoabdominals, dissections. Compared to Mayo, we did a lot more dissections there, around 40 to 50 a year. And we used to do that, the aortic on-call, so that the aortic team always came in for the dissection. So that was one of the reasons. And of course, he's a great surgeon, but I don't know whether you like that, but he's a very good singer, singing Christmas carols. So if you go back, really back in the 14th, 15th century, Leonardo da Vinci first talked about the aortic valve and the role of the cups and also the sinuses, so way back. And we all know that aortic root surgery can sometimes be a technical challenge, and for the surgeons at least, the bleeding at the end of it is always can be a problem. So when we talk now about the aortic valve regurgitation, so Jibrin has come up with this classification for aortic valve regurgitation. So it can be type 1, type 2, and type 3. So type 1 is basically type A, 1A, 1B, 1C, and D. So 1A, B, and C are usually, we can see that associated with the dilatation. And 1D is, of course, there is a perforation. And type 2 is cups prolapse, and 3 is the cups restriction. So basically, when we are talking about the David procedure, where we replace the whole of the root, it's usually being done for type 1, B, and C. And 1A, of course, the root is not dilated, so one can just replace the ascending aorta supracommissural replacement. So the pioneers of aortic valve preserving surgery are basically two who started. The big ones are the Sir Magdi and Tyrone David. So Sir Magdi came up in 1983. We published that as an abstract about the valve sparing. It's not a root replacement. He did actually replace the 3 sinuses and reimplanted the coronaries. So it's a very elegant procedure. You don't have to do anything to the root. The downside is always that because the root is not touched, especially in the Marfan patients or any other genetic disorders, the root can dilate later on. The Tyrone's technique, it's the reimplantation technique, is that it's the total root replacement, and the whole the valve is reimplanted inside the graft. So he started with this straight tube graft. So this is how the Jacob technique is done. It's called the remodeling technique. And again, the root is not touched. Of course, both the coronaries are cut out, and all the sinuses, all the 3 sinuses, or in the bicuspid valve, the 2 sinuses are cut out and replaced. And then the coronaries are reimplanted again. In case of the reimplantation technique, the David procedure, the whole of the root is, the ascending is taken out. A lot of stitches are put below the root, with also a video later on, and the whole valve apparatus is then, you can see that, is reimplanted into this tube graft. So this is how it started way ahead, and that was 1992 when he started this, or at least published in 92, and then the whole valve is reimplanted. So when you look at this, Tyrone's work now, he wrote saying that logic said it cannot work because he's taking out the sinuses and putting a straight tube graft, and whole aortic valve is reimplanted into it. So he was very careful in choosing only patients that only had the aortic dilatation and root dilatation, where the cups itself was perfectly normal. He did not do anything more. So he had only 19 patients. And looking back now, he says that he had 32 years at 15 years, Rick's at 15 years. And because he carefully chose the patients, this is very important, is that the patients we had a freedom from aortic valve insufficiency greater than mild was 92% at 15 years. And freedom from reoperation on the aortic valve was almost 97% at 15 years. This is very important. So although it is unphysiological because it's a straight tube graft, it does work. We've seen that also in Bentalls, actually. The initial Bentall procedures where they replaced the aortic valve and the ascending, they were all straight tube grafts. So this whole thing about that you need a sinus has been at least proven wrong in the practical way, at least. So we also then in 1992, actually in Hanover also we started, and 93 we started with the David procedure, and over the years, now it's more than 800. When we left in 22, it was almost 800, and now what we have the published here was from 93 to 2019, and we only look at the straight tube grafts. And I did also use about 50 of the Valsalva grafts and compared. We did not find any difference. We'll be talking about that later on. So we also looked in all the different pathologies. Like initially, of course, it was only for a root dilatation, but later on we started expanding the indication to the Marfan patients, in acute dissections, in bicuspid valves. So even though the indications were expanded, and over the last 30 years in Hanover, at least, we trained a lot of surgeons. I think about 400 of these cases were done by 3 surgeons, but also other surgeons did that. And even though there were, I think, more than 25 surgeons, because we used to train a lot of surgeons doing these procedures, the results have been good. So we could show that this procedure can be done with very low perioperative mortality, especially in elective Davis, the mortality was below 1%. And also, the long-term results with the straight tube graft are excellent. Because some people had, concerns that if you put a straight tube graft, the cups would hit against the graft, and then over the long time, there would be the cups degeneration. We did not see that. And also, which Tyrone showed that it can be reproduced by one surgeon. What we showed was that it can be it's reproducible for multiple surgeons. And we looked into the isolated groups also. So if you're looking now at isolated and elective Davis, because here we know that what is the long-term results of the David procedure. So if you look at the survival curve, so isolated Davis is an excellent. Of course, in the non-isolated, because we had dissections, we had other diseases, sometimes it's coronaries, so there are other factors that may also impact on the survival. But if you look at only the elective Davids, who only had the Davids, even after 15 years, it's almost 80%. If you look at the freedom from valve replacement, even at 15 years, it's mid-80s. Even after 20 years, it's more than 80%. So it shows that the long-term results are excellent. Again, looking at the Marfan patients also, if you look at that, again, the Marfan patients, because they are very young, the long-term results are excellent. It's almost 80% after 20 years, or more than 80%. Freedom from valve replacement, also the same thing. More than 80% had their own valve. So one of the things is that with the Marfan patients, if you wait too long, because they will come with a very dilated aorta, they may have no aortic regurgitation, only very mild trivial, but the whole root would be very dilated. What happens is that, especially in this group of patients, the cups will be thinned out. So you can see that here in one of these patients, a 32 Hager went easily through, so the root was already 34, 35. You can still do David procedure in these, but then you'll have to do something for the cups repair, and that may impact. So usually we try to catch them earlier. If you look at the acute dissection patients, if someone was young, we did the David procedures there also, and you can see that even in the long term, the valve, if you do a David procedure, the long-term results are good. And the freedom from valve replacement, even after 20 years, is 80% here also. So there's basically no difference whether you are doing in an acute dissection or in elective cases. The only thing is that, of course, in a dissection, it's technically more difficult. If you look at the bicuspid valves now, so long-term survival is good because usually the bicuspid valves are younger patients. And if you look at the freedom from valve replacement also, it's also similar to what you do with the tricuspid valve. Important thing is that with the bicuspid valves, is the quality of the valve or the valve cups at the time of index operation. Usually with the tricuspid valves on the right side, you can see that the cups are in excellent condition. As long as the cups in the bicuspid valve also like that, then there will be no difference in long-term results whether you do David on both these cases. But once you start going and doing Davids in these kind of valves, then there's no way that it will last 20 years because there's already calcification. There are groups who cut out this calcium and put a patch. Then comes the problem that which material you are using. Even if you use autologous pericardium, they are going to degenerate and calcify. Then it will not be that good. You can do it. Initial results will be good, but they will not last 20 years. So it's important that also in bicuspid valves, we repair only these kind of valves if you want 20, 30-year long-term good results. So this is how, if you look at this, the root is dilated and the cups are like this, then yes, you can do a David procedure, very good David procedures, and with very good long-term results. So this is important that we have to catch them earlier. So you can see that how the pre-op ones look, and you can repair them. So then comes what is the age. So it's a very, the older I get, you start thinking differently how old you are. So in my beginning, 20 years ago, I thought maybe I would not do Davids about after 60. Now I don't think 60 is old, right? So actually, I get a lot of patients from all over the US. Last year, I did 41 David procedures at the Mayo Clinic, and the oldest one was 74 because he came long way, he's very fit, and he wanted a David procedure. If the cuffs are perfect, and you've done a lot, and you know that you can get a perfect repair, then yes, you can do that. So age is just a number. But we looked at the data, and what we found out is that in our series, that if you compare above 65 lows and below 65, usually, you're comparing 40-year-olds with 65-year-olds or above, then the survival is, of course, is not the same, which is expected. The same thing with the freedom from reoperation. If you look at this in older patients, whether you do a Bentall, a biobentall, we're not talking about the mechanical biobentall, they will not come back. Usually most of these modern valves, they last 10, 15 years, right? So if you only look at the freedom from reoperation, they will be similar whether you do David or not. The difference will come in that because you are reimplanting the patient's own valve into the tube, that is a living tissue, and a David procedure in the long term has almost zero endocarditis. So it's the same endocarditis risk as the native valve, whereas with the tissue valve, there is about 1% risk every year. So basically, if you want to do a David in older patients, 65, 70 years old, what you are basically trying to gain is that a reduction of endocarditis risk. But the downside is that it's a longer procedure. You need about, I would say, almost an hour longer cross-clamp time. So, that's one downside. And of course, then now the question comes, can you do David procedures or valve repairs if the AR is grade 3? And Chen and his group, when he was still working in Atlanta, in Emory, found out that the severity of preoperative aortic valve regurgitation does not impact the valve durability. So it shows that even if it's a severe regurgitation, as long as you do a perfect repair, that's the important thing, then they last long. Now comes also, of course, a lot of people think that, Valsalva graft is better. Ruggiero, very good friend of mine, actually 20 plus years ago, he came up with this Valsalva graft. It does look like nasal sinuses, but what I keep on saying is that it's not nasal because it does look like that. Just because the shape looks like that doesn't mean that it's a nasal sinus because it does not contract. It's a fixed one, right? So it's not bad. It works very well, but we looked into our own data now and compared that with another center. So Eric did that together with a center in Italy, in Bologna, and we tried to compare. And in fact, in the short term, the results with the straight tube graft were better. In the long term, there was no difference at all. If you look at the freedom from reoperation after 10 years, is 86%, 87%. There are practically no difference. What we showed then here with this study, which was published in the Annals, was that the David 1 procedure with the straight tube graft is not inferior to those published done with the Valsalva graft. So you can do the Valsalva graft, you can do the straight tube graft, there's no difference. So now the question comes, why do a straight tube graft? The answer is that yes, it's technically simpler because in case of the Valsalva graft, you have to know that because the sinotubular junction is already fixed, because the graft, if you go back here, so there is the sinotubular junction. So you have to reimplant the 3 commissures exactly there. That means you have to measure the height of from the commissure up to the base of the valve. So, and then mark on the Valsalva graft and then reimplant accordingly. So technically, if you know how to do it, it's good, but you do have to measure all these things. Whereas in a straight tube graft, you don't have to measure anything. You just pull it up and reimplant. So technically, it was easier for me, at least to also to teach to the younger residents. So here you don't have to think. It's a lot easier. And it's less than 50% the price of the Valsalva graft. That may matter in some centers. So I think the Valsalva graft in US would be what, $4,000, $5,000, I forgot, around something like that. So it would be maybe 1/3 or 1/4 the price if you're using a straight tube graft. And because I operate all over the world, and I've been to places where you're teaching them this, and what you get is they take this a meter-long graft, they cut the piece that you really need, and then re-sterilize it, because in those places, it's very expensive. So in that way, I thought that why not use that? Because the long-term results are the same. I know it looks fancy, but there's no difference. And of course, the easier for the learning curve. So that's the reason that I propagate the straight tube graft. Then now comes that, of course, that patients do not like full sternotomies. This is one of the biggest lessons the surgeons have to learn, especially the younger ones, that anything we do, even the smallest procedure we do, it cannot be compared with anything our cardiology colleagues can do, because we have to open the chest, right? So we can talk, a lot of surgeons don't like the TAVRs, but I keep on telling them that the patients like them because they don't want their chest to open up. So, and patients do not care about the long term, what happens in 10 years or 20 years. So here also with the David procedure, we said that why do you need to open up the whole chest? You don't open up the abdomen if you want to operate on the heart because you don't need to see the intestine. So why do you need to see the heart because nowadays with the transesophageal echocardiography, you know exactly what is happening in the OR. So you can do this procedure through a mini sternotomy and only seeing the valve and the aorta. That's all you are operating. You are not touching the heart at all anyway. It's difficult, but it can be done. And I started that, I think, around 2009, I think, because we started with the minimal invasive aortic valve replacement about 2005-06, and then went on gradually building up. And then we started that with a mini sternotomy David procedures after doing Bentalls, and we found out that the results were the same. Of course, it's technically difficult for the surgeon, but we have to train ourselves if we want to give the best possible technique for the patients, and the patients are happy with that. And we looked at the results, equally same. There's no, perioperatively and long-term results are same as long as you do not, make any compromises just because we are making a small incision. So I'll show you a small example. A young patient, bicuspid aortic valve, ascending aortic aneurysm 6 centimeters. If you are 18, you don't care about what is done inside. Your parents have told you you need a surgery, doctors have told you yes, but he didn't want a full sternotomy. So he came a long way to Hanover, and what we did was a very good procedure. So you can see that it's very nice cups. No, that's all you see. You don't see the heart, okay? And it's a fourth intercostal space. I usually cannulate always directly, and then you can prepare. Once you clamp, you can always pull up the heart, pull up the root at least. You don't see the heart at all. You don't need to. And if you look at the aortic valve cups, perfect cups. So this bicuspid valve is going to last, hopefully, his whole life, because there is no reason for that to fail. And now if you look at the valve, at the David procedure, of course, is a straight tube graft. And then what I'm here saying is that you can just pull up the two commissures, in this case, as high as possible and reimplant it. And that's how it looks like. Perfect repair, no leakage at all now. And then, of course, that you have to walk around in this small incision to do that. One of my advantages being small is small hands, so you can go with the small ones, right? And this is how it looks like at the end, perfect repair. So this is what you need. And of course, it's important to know your own results. So one of the good things about Germany was that because of the medical system, and also geographically, it's a very small country. It's maybe smaller than Texas, I think, around something like that. I think it's smaller than Montana, in fact. So you have 83 million people cramped into Montana. That's what Germany is. So that means that also the medical system, because it's different, everyone has insurance, so nobody has to pay anything. So it's not a socialized system. Everyone pays into the system. And if you need anything, the insurance pays for it up to the last cent. There are no deductibles there. So, and usually that unless it's a specialized something difficult surgeries or difficult cases, patients tend to be local. So we get all our patients within about, let's say, 200 miles. But in case of David, we used to get patients from other parts of Germany. But again, I have driven from the north of Germany to the southern border in one day. Of course, it's 1,000 miles. There is no speed limit. You can drive very fast. But again, it is possible to drive. That shows that how small Germany is. That way, we could have 100% follow-up. So over 30 years, we had 100% follow-up of all the patients. So we could also publish, I think we had, the last count was 15. A lot of that we published together with the David procedures. So if you look at now what Craig Miller wrote in his editorial once is that, so he was also a big proponent of this procedure, and he said, but it is a procedure that should not be done on an occasional basis by low volume surgeons. It has to be done regularly in a big center, centers where doing a lot of these cases. I personally think is that the learning curve for David is, after you've assisted a lot of David procedures, maybe 30 to 50. After 50 cases, then yes, then you can say I can do the David procedure. If you do one a year, don't do it, because then the results has to be perfect. Because if the patient comes back in 3 years or 4 years, that's horrible. It has to last at least 10, 15 years, because then you are better than the tissue valve. Otherwise, you are better off doing a tissue valve. So there are other techniques also. The other one is called so-called the Florida sleeve. If you are not, a little bit afraid of doing the David procedure, one, and second, let's say sometimes you are confronted with a patient with 4.5 centimeter root or 4 centimeter root. You are doing something for the ascending. Now what to do with the root? 4.5, 4.3, it's still too small to do a David procedure. Then in these cases, and you could do a Florida sleeve. So Florida sleeve is similar to David, and I also did it, but only a lot of them for the dissections, and some for the dilated also. Here, what you do is that you prepare all around, just like with the David procedure, and both the commissures, the left ostium and the right coronaries are right and the left are prepared all around, and you put stitches all around, just like in the David procedure. Then you put a graft outside it, and for the two ostia coronaries, you just make two slits so that you are whole at the thing, you are stabilizing from outside. It's just like wearing a socks on your leg, on your foot. So that way, what this does is that it prevents the dilatation of the root on the long term. So again, follow-up, this is my own patient, 5-year follow-up. Actually, the cardiologist called me, the colleague who was doing the echo, saying that you didn't do anything to the root because he didn't see any difference. Of course, because it's a real root still. It's only been stabilized from outside, so you could do that also. So what to do if the aortic cups are diseased? If the patient is too sick for the valve sparing, because valve sparing does take longer, and if the surgeon is not experienced with the valve sparing operation. So if you are not experienced, you haven't done many, then I do not think that it's a good idea to do that. Of course, there's an old technique started in 1969, the so-called Bentall procedure, the valve plus the ascending and the root. Of course, now what we do is a modified Bentall. It's not the real Bentall, the modified where the two ostium, the coronary ostia are reimplanted. So it can be a mechanical valve. It can be a self-made tissue valve. This is how most of the people used to make it. And this is how we make it, right? Measuring you can use, for the Bentalls, I use a Valsalva graft, because one of the things I learned, because I work very closely with the industry over the years, is that one of the mechanisms of failure is that if you're taking a too small graft and putting an aortic valve into native aorta, where one of the struts pushes against the native aortic wall, all the tissue, this Dacron graft, that can be in the long term a reason for failure, because it can push into that. So I take the Valsalva graft because then you have some space there. Or over last 10 years, I think we worked from 2000, I think about 11 until 18 or 9. So there was a panel that 2 from US at that time, 2 from Europe. So Joe Bavaria at that time from UPenn. Lars is in Cleveland Clinic. And Ruggiero is the one who actually developed the Valsalva graft. He is in Rome, and I was still in Germany. So we worked almost 7 years with Edwards together to develop this, the prefabricated graft. So we don't have any royalties, again, my disclosure here. So we worked with them because we wanted something that is prefabricated, yes, with a Valsalva graft, but also it has a nice sewing ring, so that it makes it easier for surgeons who do maybe, let's say, 1 or 2 Bentalls a year. So that's how we wanted to make it. And the other thing was, we wanted to have something that if the patients come back later on for a TAVR, they can get a TAVR. So we put the 3 markers for the TAVR also. So again, there's another example of a patient that I did at the Mayo Clinic. Again, minimally invasive. So you don't need to see the heart for doing the root surgery. Here, in case it's actually a calcified bicuspid valve, you can see that. And sizing, and then the rest is just like the normal Bentall, right? So it's not difficult. Once you clamp it, you can pull it up. The only thing difference with the minimal invasive compared to full sternotomy is that if something bleeds down there, after you open the clamp, you don't see that. So everything you do, it has to be done perfectly. But I think most of the things that we do as surgeons, we don't have a second chance in cardiac surgery, so we do that. We have to be careful there. So this is how the graph looks like. And so if actually basically with this from above, you see that it looks small, of course, the incision. And the patients, I'll tell you, they are very happy. And actually I had one of my cases I remember is that I got a call from a senior cardiologist at that time from southern Germany, from Munich. And he said that, look, I've got a big praxis, so I have to go back to work in 1 week. So I need a root replacement, and I want to be home and back at work in 1 week because he can't let the patient down. So I said, okay. So he came on, he came on a Sunday. I operated on a Monday, minimally invasively. He was discharged on Friday, and next Monday, he was back at work. You can only do that if you do a minimally invasive. That's I think, the advantage. If you do a full sternotomy, it will take 2 months to heal, right? It's not that you are doing a bad job. It's just that it takes, the nature takes its course. With a minimally invasive, of course, he can't do everything, but he could sit in his clinical practice and then see the patients after 1 week. So this is one of the things. And one of the things I do is that with this minimally invasive technique is that I put another running suture all around so that I don't want any bleeding there. I did not use Teflon when I was in Germany, you know that, but now I am using it, especially for the ostia and the distal anastomosis, because I don't want any pseudoaneurysms anymore. So this is how it looks like, and the patient goes home on the 4th day. And I always do also in 3 months a CT, and for me, it has to be good and it has to look good. So I like it that the graft is cut in such a way that it's a nice curve. It has to look perfect. So it's important, I think. So I used to tell my residents that if I lose my job, I could get a job in the fashion industry for cutting clothes, you know. Anyway, so there's another one also. So there's also this ring called the heart ring. I was part of it. So every technique that came out in those days, you know, I wanted to be part of it just to see whether it works or not. You can then criticize or you learn from that whether it works or not. So the heart ring, it's a ring, it's an internal ring that is placed below the valve. So I did that, I was part of the trial, and then I stopped doing it because the results were not good enough, if you looked at that. That's one thing. Of course, they will go around saying, oh, it was a learning curve, but for me, it was not only the learning curve, you had to put so many stitches below with Teflon, just below the valve. So I did not think that it was an ideal one, because for me, still, it's the David procedure is the best one. The only role I can see here is that if it's an isolated aortic valve regurgitation without dilatation, maybe there is one group that you can put with this ring. But again, the results have not been that perfect, which should be actually. The others is the Ross procedure. Again, what we see from Europe after, spending the whole life in Europe is that there has been over last 50 years, always waves of, the Ross procedure is the next big thing. Everyone starts doing that, and then there's a big crash, and then it goes down. So this is now, we are in the midst of maybe the 5th wave now, because everyone is talking about the Ross procedure. It is a good one. At that time, we are talking about the 1960s when Sir Donald started this Ross procedure. At that time, there were no valves. So these are the times before what we see the tissue valves, that we have to look at the history also. So at that time, especially in children, he was using the pulmonary autograft to replace that. So if you're doing it in children, it's great. The disadvantage is that you are turning a single valve disease into a double valve disease. We have to remember that. And however well you do the surgery, a second cardiac procedure is inevitable, especially for even if, let's say, the autograft on the aortic position works perfectly for next whole life, there will be a problem with the pulmonary homograft. So they will come back. So surgeons have to know that. And for surgeons, it's technically challenging, and there's a long learning curve. I said 30 to 50 for a David. So the person who has done the most Ross procedures is Dr. Skillington in Australia, and he said you need 100 Ross procedures to go get over the learning curve. So it's not that easy. Again, it's a very good one for children. And comes the second thing. So this is a group, actually, this is a combined publication with Ellen, I think he's in California, along with a group in Rotterdam, and they looked at when they explanted it, they compared how the tissue was working on the native aorta and the autograft, and they found that it is not normal. It's not like the native aorta, because we know that also in children, if you're doing a switch procedure, you cannot wait 5 years or 10 years and do a switch, because the right side, because of the different pressure, starts to evolve differently. And the same thing with the Ross procedure, that if you're doing, I think, Ross up to 20, 25 years, maybe 30, it's okay. But if you're trying to do a Ross procedure at 60 years, I'm now 58. I do not think that my right-sided pulmonary valve, aorta will be, pulmonary artery will be the same quality as the left side, because I've had almost 55, 60 almost 58 years where the pressure was different. We know that from children. So why should it be different with the Ross procedures? So this is one thing we have to know, is that the failed pulmonary autografts, it's not only that a technical failure initially, yes, that's one of the parts, I'll come to that later, but also even if you do a perfect repair, there will be some sort of problems later on because the quality of the autograft is no longer the same as the aorta. So we have to keep that in mind. So young patients, I think it's good for the Ross procedure, not in above 50 years old. Technically, it may be initially okay, but it's not going to last 30 years. And again, you are changing a single valve disease to a double valve disease. So so now this paper also looked into different ways, and conclusions here was that the autograft replacement, the stented prosthesis without the aortic replacement can be done. If they come back and they replace only the valve, it can come back. But again, they again say that there can be progressive root dilatations even then here. So they looked at what to do in autograft reoperations after Ross procedures. So Jochen Schaeffer does a lot of Ross procedures. He talks a lot about that. But then he also publishes, and he says it's a great operation, yes, but he has his own publication showing that 30 consecutive patients where he had to redo them. So, and most of them, 25 of them, were because we did the full root replacement, and there was a problem. But even if you don't do that, there can be dilatation. So this one of the reasons is that because the autograft acts differently as soon as it's put from, let's say, 10, 15 pressure to 120, 130 pressure, right? Suddenly. So, and then in these 30 patients, 25 had a full root graft. And they come back. And it's not that after 20 years, they come back for 4 or 5 years. And that's horrible. I've done several redo Rosses, operations after Ross, and they did a valve sparing route. And the patients were very angry in the beginning because they were told by the initial surgeon it's going to last forever. And the patients, especially who are upset, are about 50 and above, right? They do not want a redo. That's why they went for Ross. So again, maybe I'm biased, but I do not like Ross procedures after 50 years old. So autograft, again, the same thing here. Mechanisms of autograft failure, there are 2 different mechanisms according to him. One is that dilatation because of the technique. If you're doing a full root replacement, just as a homograft, it can dilate. But also there is a lesser degree of autograft dilatation, even if you do all sort of things, because the tissue is different. So it's not that you are doing something wrong. So you can do a David procedure. There are groups that have done a lot. So you are taking out basically all of the autograft and then doing the David like I showed before. So the cuffs itself is not a problem of the cuffs because aortic valve is basically, the 3 cups there's no special mechanism stopping the blood there. So it can be done. So again, here's the same thing. They looked into their data, so it keeps dilates. And then there's the most famous guy who had a failed Ross in the world, right? So 1990, he had a bicuspid aortic valve. He could have got a simple aortic valve replacement, 1997. No, but he was told that, oh, you do a Ross, you'll be the best, for the whole life. He went for a Ross procedure. There was a failure. So next day they had to take him back and put on both the sides, he had 2 homografts then. So that was 97. And then 2018, he came for a failed pulmonary side. Then he got a TAVR. And the TAVR, there was a rupture. So they had to emergency operation, and they had to replace the TAVR plus the whole pulmonary valve homograft. That was done in 97. So he got a pulmonary homograft. Then again, 2020, his homograft on the aortic side failed. So he had to get a redo Bentall then. So of course, he survived all these. But for me, the lesson is that he was already around 50, I think, at that time. So he would have been better off. Maybe if I was the patient, if he didn't want to take Coumadin, maybe a minimally invasive surgery with biological valve, tissue valve. Anyway, but at the end of the day, needs of the patients come first. There are different ways to skin a cat, they say, so we need to have different techniques for different patients and different pathologies. This is the patient, actually, he's 77 years old. So he came with a root dilatation and aortic valve regurgitation. And he's very active. So at that time, I said, look, I could do a David, but I said, look, it will take longer, and one of the cups was not working properly. I could have maybe done a lot of cups repair, but I thought that the long-term results will not be good. And I told him that in 3 months, he can go back to his normal life. I never thought that he would do that exactly on the third month. So he came the next day with this video and said, please show it to everyone. I'm going back to my normal life. This is what he does every day. He lives in Texas, so he can do that in that weather. Anyway, so this is important to understand also that we have to look at that. But after, again, like Eric said, I was born in Nepal and in the Himalayas, and then spent my whole life in Germany and now in US. So we all come, it's only a question of how far you want to go. So if you want to go 50,000, 100,000 years ago, we all come from East Africa. So that's what I'm learning, that wherever I go and do the surgery, I've done surgery about in 50 countries now, or 50, I think 51 now, is that once you open the chest, the heart looks the same. You don't even know what the ethnicity of the patient is. So I just want to say that. Thank you very much again. And just in conclusion, sorry, is the Bentall procedure is still the gold standard, because at the end of the day, it will work. But for the morphologically intact valves, if the cuffs are normal, I think repairs should be done. And if it's a young patient, if you are not doing the repair, please send them to surgeons who are doing a lot of repairs, because that will last 20 plus years. So it has good long and short-term results, of course, and very low rates of complications, not only bleeding, embolization, but also endocarditis. In the whole 800 patients in Hanover over 30 years, the endocarditis risk was 0.2%, so not even 0.5%. Just like the native aortic valves. In patients with aortic Marfan syndrome, bicuspid valves, we have to do a careful selection. In the bicuspid patients, if the cuffs are normal, yes, but if it's calcified, no. It will last maybe 4 or 5 years. Then if they come back in 4 years, it's a bigger operation. So you are better off doing a Bentall, which will last 15 years nowadays. And of course, you can do a minimally invasive procedures also. They are comparable. In selected patients, again, you have to look at the CT scan. You do have another 4 or 5 years of learning curve as a surgeon to do that, but it is possible. Thank you very much. So, yes, sir.
Thank you very much. Benson, I did my first David procedure in 1997, so I would say I do a half dozen to maybe 10 a year. My question is, the ones that I think that I have the most difficulty with are the ones who have leaflet edge thickening, right? So the root itself is what's the primary mechanism. But then, I get them late, and so the leaflet edges at the nodes of Orontius, they're thick. So in the past, I've done this a few times where, I kind of shave it off and I get it really thin, and then, I test it. But those are the ones that I have the most challenge with. The last one that I did that I had to replace the valve after doing that was a congenital. She was exactly that, a Ross procedure, whom we were trying to do a valve spring root, but the leaflet edges were a little bit too thick. We shaved it, didn't like it, and then we ended up just doing a tissue valve on the inside of that thing. But what do you do besides? Is there anything else that you do in terms of when you have these, the annulus is dilated, you can do the David procedure, but the leaflet edges are a little thick, and it's not a thing, they're not coaptation issues. Well, it's a coaptation issue really right at the distal edges where the center is thick. What is your technique?
So the thickenings come from regurgitation. The longer,
Correct. Yeah, I get them late.
That happens like that. So I also shave them. So if the thickenings have turned into calcification, then no.
Yeah.
They will not last long. I mean, we are talking about, for me, a David procedure is a good procedure if it lasts at least 10 years. Because that is what the modern tissue valves last, right? So anything that lasts less than 10 or less than 15 is not a good repair. So I just shave it also. I usually use the bigger grafts, 30 plus, and then I downsize this to 26. I put a Hager in and then put this running suture all around to make it 26.
So you downsize it more.
I go down to 26 because 26 is usually the size of a normal root. That's the upper limit of the normal root, right? And 26 is also, I also think about what happens in 15 years. Let's say I'm doing a 60-year-old David, 15 years, 75, 20, 80 years old. If they have to come back, then I want to make everything perfect for a tower. So I think every surgeon has to think about what may happen later on. Yeah. And if you want to do a tower, so and then I reimplant a little bit higher, and then I downsize to 26, sure, so that you can put a tower there.
Yeah, pulling it up higher is like making a neonatal aortic valve, which is a good technique. I've always been concerned, so let's say I put a 20, I've never gone to a 26 for a graft ever, but if I did that and then I had to replace the valve at that point, it's because I was unhappy with the leaflet edges, then you're very limited in what size you can get in there at that point without redoing the whole root.
Eric knows that I always used to tell my residents that if you cannot do a Bentall quickly, then you should not be doing a David. So if I'm not happy, it has happened over the last 20 years that maybe I would say under 10, I've replaced at the end, like I said, if I'm not happy or there's something, then I take out the whole thing and do a Bentall. It takes me 30, 40 minutes to do a Bentall because taking out the David procedure at the same time is 5 minutes. They're taking out this whole thing and just do a Bentall. So you can go to, because for the Bentall, because it's a dilatation, means that you can go 25, 27, 29 valves, which is good for maybe 2 towers later on, right? So I'll go for 27 or 29 Bentalls then.
It was nice to see Eric on so many papers with you. Can you comment on the valve repair at the time of aortic dissection? I know that's not a common thing, but how do you approach it?
Yeah, we did that a lot. So in cases of dissection, I do it differently now in Mayo because first of all, we get only 20, 25 dissections a year. And most of them have come from North, South Dakota, 10 hours, 15 hours, something like that. In German system, from the time of pain to time of surgery was under 6 hours, right? So very quickly. And if someone was young, below 65, we used to do a David procedure and a total arch replacement with a frozen elephant trunk. The whole elephant trunk technique came from Hanover. So for a lot of residents or even younger surgeons, doing a total arch with a frozen elephant trunk was not considered that difficult. If you a minimal invasive mitral was considered a difficult operation, right? So that's how you see, if you see many, we're doing 50, 60, 70 frozen elephant trunks a year, so it was considered normal, so we did that more. And if the root is dilated, young patient, the root is dilated, let's say 4.5, 6, 5 centimeters, I would go for a David procedure if the cuffs are normal. If the root is not dilated, and small, I just did what Joe Bavaria used to publish, putting Teflon in the new media to just do a step, repairing the root. If it is in between, let's say 4 centimeters, I did, in those days, at least the Florida sleeve also. There are different techniques. If the cups is damaged, then of course it's a Bentall then. And of course, I published, I think he was the best resident I had in terms of publications. At least we published, 50 at least papers together. We're publishing 15 a year actually. Because again, the system was different. I see that in Mayo because we had 100% follow-up for 30 years because of the unique situation of German medical system. Here, it's very difficult because 1.5 million patients come to Mayo and they all come from all over the world. We have no local patients. Right? So long-term follow-up is almost impossible there.
Thank you for pointing out my name on the papers, and thank you for giving me an extra slide with so many fun pictures in the OR. Really appreciate that. Any more questions from the audience? I think I have one. I mean, you mentioned that early on, like 10, 20 years ago, you thought like David should be done in patients under the age of 60, and now you go up with your age limit. Do you think there's a changing role for the David procedure in the setting of a connect graft that you also presented? I mean, they claim Edwards says the tissue, the residual tissues better last longer, and now we have TAVR. Do you think there's a changing role because patients might be also better off or might be well off with a connect graft and then a TAVR in 15 years or something? Do you think there's a...
So 2 points actually. If you only talk about freedom from reoperation, then maybe there's a difference because Edwards has been pushing that. Although I was part of the development team, again, I did not have any royalties. And this is what the Edwards says. But the residual tissue came in 2017. It's only 7 years, 6 years, right? So they don't have this long-term results that they say. They can say 20 years. I tell my patients around 15 years because I don't know, 30 years, right? Because the older valve they had was the Magna East. They didn't last 20 years. They may say 20 years, but I would say 10 to 15. So that's one thing. The second thing, I do not look at the age written on the paper anymore. I look at the patient. So there are patients who are maybe 70 and look 90, and there are patients like this guy is 77, but he's actually biologically at the most 50 in my view, the way he was and the physical activities he was doing. So I look at the patient, and if someone is very fit, yet like last week I did one who was 70 plus, he's doing 100 days of skiing every year, full time, downhill skiing. So I did a David procedure on him. But if someone is, you look at 70, look 70, and then maybe I would do Bentall, because again, even for me, after doing so many Davids, it takes at least 45 minutes less or half an hour less of cross-clamp time. Right? That's a factor also. And you know that at the end of the day, with the Bentall is going to function, short term at least, long term, okay, 10 years. But then the second point is that there is a risk of endocarditis. Whichever valve you put in, any prosthetic valve has an endocarditis risk, which the David procedure does not have. So that's one thing you have to remember, but you have to be able to do a perfect repair. The third point would be that Edwards, I hear that has been going around, and a lot of places where we used to, send the patients to a bigger center for David procedures have been cannibalizing with the clinic. That's what I heard in US. So there will be some patients who will get that. But if someone is young, especially under 50, 55, valve is okay, I would still go for a David. And if you are not doing a David, please send them to places where they do David.
You also mentioned other techniques like Florida sleeve and the Yakub procedure. What do you think is the role of those procedures compared to David? I mean,
yeah, I think for Florida sleeve again, if a patient already have 5.5 centimeter aneurysms, I don't think that Florida sleeve is a good idea. If something around 4, especially in dissections, I've used that. If it's around 4 centimeters, everything is dissected, and then you could do that, because you don't have to re-implant the coronaries. So that's the biggest problem in acute dissection, re-implanting the coronaries. However many dissections you've done is always tricky. So that's one part. That's why some people just use glue and do that. You can do that, And in dissections, I think you can do anything to get the patient out alive. And then a redo it can always be done later on as an elective procedure. So Florida sleeve, I think if it is 4, 5 years, but not if it is 5. And Yakub, I'm not a fan of Yakub, because unless it's an old patient, 70 above, and then you are replacing all the 3 commissures, okay, but Yakub does not stabilize the root. And one of the biggest, what Sir Magdi himself used to say was that, oh, this is a better procedure than David, because I'm not doing anything to the root, and with every heartbeat, the root can expand and contract. That's what he said. And then the downside is that it starts expanding. So the new techniques like putting a ring inside, like the heart, or the heart is usually done with a ring inside and a Yakub procedure, or doing an outside procedure like the French guy, then if you are taking the whole thing out, that's saying that, suppose the advantage was that it expands and contracts, it doesn't expand and contract. So why do that? And with the Yakub, especially dissections or very thin aortas, if it bleeds on this suture line, it's difficult. In David, it can never bleed. It's inside, right? So it's hemodynamically for the surgeon, or hemostatically for the surgeons, it's easier procedure. It never bleeds them. That's why I think David procedure is the easier one. It's the cheapest one. You don't need any outside ring, inside rings. The rings cost, I don't know, $10,000, $5,000. So why do that? The graft in Europe used to cost $400. And in some countries, like I said, 50 centimeter graft, you can do 5 patients.
okay. I think no more questions. Thank you very much. Great talk.